Everyone. Welcome to our session. We're just going to wait a minute or two to let more people log on before getting started. All right, I'm going to wait for another 30 seconds since I hear a few more beeps before we get started. Good morning. My name is Kama Scoffrey, and Tabia Akintobi and I run the Social, Ecological, and Behavioral Science for Health Equity Core of the Georgia Diabetes Translation Center. We thank you for coming this afternoon. We hope everybody had a great Thanksgiving. I'm really delighted to have Dr. Lillian Madrigal come and present on some of her work using an implementation science theory. So the run of show is I'm going to do a brief introductions on dissemination and implementation science theory. And then Dr. Madrigal is going to present on her diabetes translation work, and then we'll have Q&A at the end. So I'm going to go ahead and get started and share an overview of dissemination and implementation science theories. Can everybody see the screen? Great. So just a brief definition of dissemination and implementation science theories, and then a focus on theories. Theories are just ways of understanding behaviors and events, and in the dissemination and implementation science world, it's often what we do in health systems or public health or social service agencies in terms of implementing evidence-based practice. We're trying to understand what are common elements or factors related to implementation and or dissemination, scaling up of programs and things like that, which Dr. Madrigal will be talking about. And they help us as researchers to understand the factors that will guide our future practice for implementation. So what are the aims of D&I science theories and frameworks? First of all, they describe important factors and help guide our implementation of the translating of evidence-based practice or interventions into different practices or settings. Sometimes they're very important to our understanding of what are important constructs that influence implementation, outcomes, or dissemination. The other thing that they help us do is to understand context and contextual issues. So how are our organizations functioning? Is there good communication? Is there leadership support? what is the context we're implementing? Is it in a hospital? Is it in our FQHC, a federally qualified health center that might have lower resources? It could also help us with evaluation. So one study looked at some of the common D&I theories and frameworks employed in the field, and this is just a snapshot of some of their findings. And you'll see here that the Consolidated Framework for Implementation Research and the REAIM or Reach Effectiveness Adoption, Implementation, and Maintenance frameworks are used the most. Other ones that are used are diffusion of innovation and theory of theoretical domains framework. So I thought it might be helpful if you're interested in D&I theories and frameworks to look at this Nielsen article that really categorizes D&I theories and frameworks into 5 different groups. The first one is process models. These models help to outline the steps from translating evidence-based interventions or strategies into practice, such as knowledge to action frameworks, and there are many of them out there. The second one is determinants frameworks, where it looks at personal, social, economic, or environmental factors and others that influence implementation. We heard of the Consolidated Framework for Implementation Research, or the Theoretical Domains Framework is another example. There's also implementation theories that help describe different aspects of implementation, such as the COM-B model or organizational readiness models. There are evaluation frameworks that kind of specify what are important aspects of implementation to consider or assess to determine EBI, evidence-based intervention effectiveness. And then, of course, there are classical behavioral science theories and models that we use, such as diffusion of innovations, social cognitive theory, theory of planned behavior, etc. So in finality, if you're interested in D&I theories, this is a great website. You'll see the website link, dissemination-implementation.org. It has a guide that will help you select theories that are focused on dissemination or implementation. And it also has a lot of different theories or models highlighted in, for example, this TTAC review that had 61 D&I theories and models. So that's just a quick overview, and then we're going to get into a direct application with Dr. Lillian Madrigal's case study. So thank you, Lillian, for presenting today. And while she's getting her presentation up, I will do some quick introductions. Dr. Madrigal serves as the Director of Implementation Science and Practice at the Emory Centers for Public Health Training and Technical Assistance. Her work focuses on implementation and evaluation of evidence-based interventions to promote health behaviors and outcomes, particularly in diabetes. In her role at the Emory Centers, she works on a variety of projects across all the sub-centers, DTAC, EnCORE, PEQI, and TTAC, providing subject matter expertise on research and evaluation designs, mixed methods data collection and analysis, scientific writing, training and curriculum development, and technical assistance delivery. She received her PhD from our department, Behavioral, Social, and Health Education Sciences at Emory University, Rollins School of Public Health, and she holds an MPH from the University of Michigan School of Public Health. Prior to joining Emory, she worked as a senior research scientist at ICF, which is a global consulting company, and she was also an ORISE fellowship in the CDC's Office of Smoking and Health. Thank you very much, Lillian, for joining us today.
Thank you, Com, so much for having me. So I think everyone can see my slides. I'm excited to be here today and talk to you about some of the research that I have been doing with a great team. So as Com said, hi, I'm Lillian, and I'm at the Emory Centers for Public Health Training and Technical Assistance. And one of our sub-centers that you may be more familiar with is the Diabetes Training and Technical Assistance Center, DTAC. And so for over 10 years, DTAC has worked on scaling the National Diabetes Prevention Program and was the first recognized national DPP training entity. Since then, DTAC has trained over 5,000 lifestyle coaches who implement the program. And they've trained coaches from all 50 states, as well as many locations outside of the US and in over 2,000 unique organizations. In addition to lifestyle coach training, DTAC also works on various other efforts to improve the implementation, increase the scale, and sustain the national DPP, one of them being conducting implementation research on the program. So in the fall of 2019, Emory was selected as one of 9 awardees to be a part of this in-year research strategy led by CDC's Diabetes Division of Diabetes Translation. And this was a collaboration project between DTAC and the Georgia Center for Diabetes Translation Research, and with staff from both. So we had co-PIs, Dr. Linnell Blaise and Dr. Mary Beth Weber, who's on today's webinar. So hi, Mary Beth. And today we'll share findings from a study that was part of this project, and then a follow-up study that we conducted. So as many of you are aware, the National Diabetes Prevention Program is the CDC initiative that started in 2010, and it's to scale a year-long group evidence-based lifestyle change program across the country. The national DPP has focused on scaling this program by building up the workforce, developing quality standards, recruiting organizations, finding sustainable ways to fund the program, and developing referral networks to recruit participants. And the initiative has had great success with scaling the program, right? Today, there are over currently 2,000 organizations across the country registered with the CDC implementing the program. And as of March of this year, over 600,000 people have participated in the program. But we know that prediabetes continues to rise in this country. The latest CDC report has 96 million US adults in the country having prediabetes. And it's estimated that to tackle this at a population level, the national DPP needs to reach around 12 million people, so that there's still more scaling that needs to be done, right? We need to reach more people. In my previous work before coming to Emory, I had visited organizations across the country implementing this program with varying degrees of success. So many types of organizations deliver the DPP: hospital systems, YMCAs, health departments, universities, employers. Emory has a program, right? So with a vast diversity of organizations delivering this program, I began to question, what are those internal and external factors that support implementation among national DPP delivery organizations? And presented here is a framework used by Choudwar, Duggan, and Barr that depict those multi-level causal factors that impact implementation. The research I'll be sharing with you today focuses on the internal organization factors. So this encompasses organizational resources, leadership, communications, infrastructure, and then the external organization factors at the structural level. So these are, the context in which an organization operates in, the political environment, relationships with partners, things like that. And so how did these two levels, these factors, impact the implementation outcome of REACH? That was my focus. So, and REACH is to what extent individuals within the population of interest are reached by the program. And we operationalize this through enrollment. So as mentioned, the program has had many people in it, but needs to recruit many more in order to make that population level impact. And so a key aim for the national DPP has been to increase that enrollment. Scientifically, we call this the butts and seats problem, if you haven't heard, but most of the research for the national DPP has really focused on those participant level factors to enrollment, right? who tends to enroll? What are those demographics? You know, how are individuals recruited? What do they like? Those sorts of things. It's been very participant focused. But we think that it's equally important to focus on those organizational level factors as well. And having a better understanding of which organizations are successful with enrollment helps us to better strategize and build capacity in areas related to reach, both in internal scaling, so getting current delivery organizations to increase their enrollment numbers, as well as you know, recruiting and onboarding new organizations to deliver the program successfully. And so to operationalize these organizational and structural level factors, we use the Consolidated Framework for Implementation Research, CFIR, which Com just shared with us, is very popular within implementation science. And in particular, I focused on the CFIR inner and outer setting domains. So the inner setting domain constructs aim to capture that complexity within organizations related to implementation. And the outer setting constructs provide insight into the greater environments and external contexts which constrain or facilitate the organization's ability to carry out the intervention. And CFIR developers, as well as other researchers, have spent a lot of time defining these constructs and providing resources to capture, measure, and assess them. So the first study that I'll share with you today was qualitative in nature, and the main research question was what organizational and structural level causal factors contribute both in magnitude and valence to the organization's current level of implementation reach. And that was followed by a quantitative study, which asked, you know, what are those direct and indirect relationships between the CFIR inner and outer setting constructs and reach. So in the qualitative study, we conducted key informant interviews via Zoom with 30 national DPP organization implementers. So these were from separate organizations. We talked mostly with the program coordinator at that organization. And we use adapted questions from the CFIR qualitative interview guide. If you've never used CFIR or gone to their website, they have a lot of great tools that you can use, including an interview guide. And so we took those inner and outer setting questions. And we also asked about, this was right at the height of the pandemic. And so we tried to focus on pre-COVID implementation as much as possible and kind of saved the end to discuss how COVID in particular has impacted their implementation. So organizations were selected from a list of national DPP implementers interested in participating in this study that were part of our DTAC network. So DTAC has, like I said, trained, you know, over 5,000 coaches. They have a lot of folks that are still subscribed to all of their resources and part of online groups and things like that. So we were able to recruit from that population that is engaged with DTAC. And organizations were stratified into implementation reach levels based on their organization's average enrollment per year. So we had high, medium, and low reach levels that were determined using national level participant enrollment data from the CDC in 2019 when we started this work. So organizations were then purposefully selected to sample, you know, the diversity of implementers and organizations. The goal was to recruit around 10 organizations from each implementation reach level, and we did about that. And there was also variation and good representation among organizations regarding the type of organization where they were, the length of delivery, their location in the US, the participant population that was enrolled in their programs, and other factors that we looked at. So for the qualitative analysis, we used a construct rating method. So to describe this simply, first you code your interview transcripts by CFIR construct, then you rate those coded segments within each constructs for valence. So that's a positive or a negative example, and then magnitude. So how strongly did it impact implementation positively or negatively? And at the end, you produce a matrix and interpret patterns you identify in the data. So here's our final matrix, and it's a lot to take in. I don't expect you to read it, but let me walk you through it. So this matrix is sorted by those implementation reach levels, as well as organization type. And we used average scores by construct and level, as well as by organization, to explore patterns in the rating data. And so you can see kind of this heat map we've created where that blue is positive, the yellow is negative, and the strength of the color kind of shows that those extreme scores. Instead of using associated with reach, which is statistical language, in this qualitative analysis, we discussed distinguishing constructs around implementation reach. And 4 of these constructs were identified based on differences between groups by average rating, the examination of the number of extreme ratings, and the thematic analysis based on the content discussed. So the following 4 constructs, subcontracts were identified as distinguishing: structural characteristics, compatibility, goals and feedback, and leadership engagement. So let me talk to you about some of the findings within each of those. So structural characteristics, this CFER construct is comprised of many of these traditional measures of context and organization characteristics. So their size, their type, location, etc. So when we compared between reach levels, we found that high and medium reach organizations described both positive and negative examples related to implementation, while the low reach organization discussed mostly negative examples. So for example, one awardee discussed both the pros and cons of being a larger organization, saying, I think our size is a pro just because we have a large population to draw from. One thing that can make it a barrier, though, as far as trying to get referrals and spread the word, is when it's a huge organization, it's hard to get the message across when there's just so much other stuff going on. So you can see how that part of their infrastructure or their organization size had both the kind of positive and negative. On the negative side, one organization described their organization infrastructure as really tedious and it becomes a huge pain. So talking about how some of the structures they have in place impact program implementation negatively. For the compatibility construct, high and medium reach sites more often described strong positive examples. So organizations often had these high and medium reach sites often had complementary programs. So a diabetes self-management program or something like that, that allowed them to more easily adopt and implement the national DPP. In the strongest examples, organizations shared how their other programs referred participants to the national DPP and vice versa. So for example, the national DPP was said to be a nice complement, and it rounds out the services that we offer. For those who described this construct negatively, they noted how the DPP was different from typical services and programs and not embedded in their current systems, saying things like, we have to force it to fit. For goals and feedback, we found that high-reach organizations discussed formal enrollment goals and provided feedback to the team around those goals, while medium and low-reach organizations tended to have no formal enrollment goals set. So one interviewee described how the enrollment goals facilitated enrollment by saying, we always have an enrollment goal, so we always reach the goal and we have a waiting list. It's nice to have a number. I like numbers. Tell me what you want. I'll go for that number. That's a very nice quote about how enrollment goals motivate the organizations to reach that goal. On the, for the medium and the low reach organizations that tended to not have these enrollment goals, it was due to many reasons. In this one example, they talk about how they were focusing on other implementation processes. So they say the national DPP, it's so new that I don't even think they would even know where to begin. We have this great program that's been developed by the CDC. We're implementing it, but we kind of need to establish a further way of recruitment. They're not too hardcore. So they're kind of talking about how they don't have any enrollment goals yet because they're focusing on other things. For leadership engagement, the majority of interviewees said they have support of some sort, but what this actually looked like when we asked them to describe, this varied greatly. So high and medium reach interviewees more often described very active leadership engagement and connected this with positive examples of successful enrollment efforts and growing the infrastructure of the program. So one interviewee said, our leadership has been great. They really came together and got everybody on board, and we were able to get those numbers and submit that application. Here they're kind of talking about growing their program, applying for the Medicare DPP. So that's how their leadership helped them. Low reach groups had more mixed experience with this construct, and leadership was described as not being engaged enough, not doing enough to understand the program, and taking a very hands-off approach. So this quote, you can see they say, I think leadership just to actually sit down and understand the program a little bit better, and understanding the goals that are attached to it, and understanding the work that's needed to get done, that's it. I think that's where the gap comes in. So they were struggling a lot with that leadership engagement. So here I've highlighted all the constructs included all the constructs we looked at and highlighted the ones that we're distinguishing. And you can see a lot we're not distinguishing. And even though there were no differences between the reach levels, we still found very insightful themes across interviews. So this just means maybe the same types of things were happening regardless of reach level. And so we gained a lot of rich other details about the implementation process within these other constructs. They just didn't rise to the level of distinguishing based on our analysis that we did. And happy to say that these findings this study was published last month. And I'll have an article that I believe Jeff will send out with my slides after today's talk. So if you are interested in hearing more and more specifics about what we did, please read that article. So in the follow-up study, we did this quantitative study, and then we wanted to quantitatively examine the direct and indirect relationships between these constructs. So to do this, we use structural equation modeling, which is a statistical technique used to measure and analyze the relationships of observed and latent variables. And so this is the hypothesized, theorized model that was initially created. And you can see the outcome of interest here at the end is that reach or enrollment. And there were three main hypotheses. So the first one being focused on some of those intersetting constructs, so that the networks and communications and culture constructs have an indirect relationship with reach mediated through implementation climate and readiness for implementation. So in other words, we split up these intersetting constructs to see if the implementation focused ones were influenced by the other more general internal organization constructs. Then we have the outer setting constructs, and these may have a direct or indirect relationship with reach, as well as the inner setting constructs along that first pathway. So basically, saying that these factors external to an organization can impact the internal pieces as well as the outcome. And then the third is structural characteristics, which is an intersetting construct that was operationalized using organizational characteristics variables. And those may also have a direct or indirect relationship with reach, and also anywhere of the other constructs. So in conclusion, we threw up a lot in this model to explore, what might be going on. And the data that we used to test this model was through an online survey distributed in August 2021. And we used, once again, that DTAC population. We sent the survey to over 6,000 national DPP implementers in our DTAC network. We had some incentive funding and collected data for 5 weeks. And after cleaning, we had 586 responses. Those that were eligible to take the survey were national DPP staff members who had either one or more of the following roles. So they were a lifestyle coach who deliver the program to participants, master trainers who are lifestyle coaches that also train new coaches and do ongoing training within the same delivery organization, and then program coordinators who supervise daily operations of the program, provide guidance and support to lifestyle coaches, and monitor and submit all program data to the CDC. So the full survey included 101 items requesting information about the respondent, their organization characteristics, enrollment level to date. We had 38 Likert scale items related to those C for inner and outer setting constructs, and then 40 items from the program sustainability assessment tool, which we use for a different analysis more focused on sustainability. So since there are no standard measures for these CFIR constructs, 24 of the CFIR items were adapted from existing scales and studies, and then 14 were newly created with subject matter expert review. And to keep the survey length reasonable and reduce burden on participants, we focused on areas that were most relevant based on that first qualitative study that I just talked about. And then also the structural characteristics items, we used the organizational characteristic variables instead because there was a lot of overlap there. It reduced the burden on participants. And this is something that's commonly done in similar studies. So once again, the study, like the first one, had good representation from a variety of organizations, different types, different lengths of delivery of the program, CDC recognition status differences, the location, varying participant populations that they have enrolled. And about half of the respondents reported offering the program in person. And because this was during COVID-19 pandemic, the vast majority were also delivering the program in some sort of virtual mode. And I just wanted to point this out because before the pandemic, the majority of programs were exclusively delivered in person. And so this is a very big implementation change that has happened over the last few years. So in addition, to get some context on enrollment, I asked, how would you describe your current DPP enrollment level? And 56% said they are actively working to increase enrollment numbers. 15% said they were comfortable with the current level of enrollment, and 10% said that they would like to increase their enrollment. However, they were limited by capacity at the moment. So in terms of internal scaling within organizations, that's 25% of organizations who are not looking to enroll more people, which I found very interesting. And then I also asked, to what extent do you agree or disagree that COVID-19 has prohibited you from enrolling the desired number of participants in your program at this time? And no surprise here, half of the respondents said they agreed or strongly agreed with the statement. So here are a look at some of the CFIR items that we used. They were rated on a 1 to 5 bipolar scale. Higher ratings indicate agreement with positive statements related to implementation of the construct. So on this table, I've included kind of 2 of the highest and lowest rated items. So for the highest rated item, many agreed. There is a strong need for this program at our organization. On the other hand, the lowest item was there was some disagreement, more of a range of responses around if the national DPP staff at the organization are receiving some kind of acknowledgement for implementing the national DPP successfully. So any kind of award or bonus or incentive, that sort of thing. And so that ended up being slightly below neutral. And then this table just shows the aggregate construct scores, and our Cronbach alpha ranged from 0.69 to 0.93, which are all good scores that indicate that internal consistency of our measures. So they say that so this tells us that our items worked well together and they measured what we'd intended to measure, which are those CFIR constructs. here is the final model. In the end, I created 3 latent variables to capture those inner and outer setting constructs. The model fit was good. There were significant direct paths between those CFER latent variables, but no paths, direct or indirect, from these variables to enrollment. However, 9 of the CFER structural characteristic variables had significant direct relationships with enrollment. So let's look at those. So the length of delivery, the number of lifestyle coaches an organization has, the number of full-time staff, if they were a larger organization, and organizations delivering in rural, suburban, and urban settings. These all had positive, significant direct relationships with enrollment. So for example, when you look at these parameters, they can be interpreted as, so within this model, for every additional lifestyle coach at an organization, enrollment increases by 47 participants. On the other end of our results, organizations that identified as academic organizations and those with not only non-white participants enrolled in their programs had a negative direct relationship with enrollment. So if they identified as one of these organizations, this reduced their enrollment. And you can see here that the staff variables had the largest effect sizes. So in conclusion, based on these 2 studies, what I think we can take away from this is that, 1, basic program infrastructure and support like staff time, resources, active leadership engagement, these were very salient to the implementers and important in these studies. So these are very practical, maybe obvious things, but I think the more evidence that we have to support and emphasize that staff don't just need quality training, but they need those resources and time and supportive organizational environments to actually do what they're trained to do is very important. These findings also suggest that more guidance and resources could be provided in these areas of program infrastructure, compatibility of the program, goal setting, and leadership engagement for delivery organizations at all phases of implementation. For example, the CDC uses an organizational capacity assessment that delivery organizations can use at the time of adoption, including some of these CFER constructs in this tool could perhaps make this assessment more comprehensive and impactful. And then lastly, organizations serving specific populations like non-white populations, they may have specific needs or challenges. And many other others in this space, in the national DPP space, have noticed this, have been working to focus enrollment and retention efforts within these groups. And so I think our study just adds to that work and supports those initiatives. There have been few studies of the national DPP that examine implementation at the org level, and in particular with the number and diversity of implementers that we were able to engage. And I think this is some of the first work of the national DPP using the CFER. And so in terms of future directions at DTAC, we have also been working at another level, the provider level, focusing a lot on key factors that contribute to lifestyle coach success. And so we're really looking at how can we bring all of this work together at the many levels to understand implementation of this program. And then, putting this research to practice. The benefit of working at a place that provides technical assistance is you can automatically put your research findings to work. And so we are, in all the trainings that we are providing, we are using the findings here to do that. In fact, that org capacity assessment I was just talking to you about, we did a training recently and we talked about some of our study findings and how to enhance conversations while using that tool so you get at some aspects that aren't currently asked about in the assessment. And at DTAC, we are also always working on population-specific adaptations of the national DPP, focused on how do we implement our work with a health equity lens and really focus on maybe some of the most at-risk populations or those that are not as are underserved or all those things. So we are very happy to be able to use these findings in our TA and have other research ideas coming. And like I said, we also did a sustainability study that I'll be presenting at the Dissemination and Implementation Conference in December. So if you are there, please visit and learn about that. But that is kind of all I've prepared today. So Com, I can hand it back over to you.
Thank you very much, Lillian, for your presentation. I really liked your sharing both the qualitative and then the survey with implementers to kind of understand organizational level variables at both sessions. So if people have questions, feel free to either type them in the chat and I'm happy to read them, or if you want to come off mute, then we can also have you relay your questions and have Lillian answer.
Hey, this is Raquel Quarles at Morehouse School of Medicine. And thank you very much, Lillian. Great presentation. I appreciate all of the information that you provided, and I'm looking forward to getting your article. Congratulations on the publication last month. My question had to do with, I'm thinking through like your finding about the non-white participant success, and also thinking through those large versus small organizations that are implementing DPP. And I'm curious what, if you were able to look at SES of perhaps the organization at the organization level, or the people that they target, if you saw any differences there. Did you look at that?
Yeah, those are really great questions. And I wish we had, I guess, the ability to do that. So one of our limitations was because we don't have access to CDC data for a number of reasons on their end, you know, we had to ask organizations to self-report. And so it was just a matter of limiting the burden on our participants on providing that. So we were able to, some of the racial ethnic categories, like those priority populations, what they call us, is very much a focus for this program. And so that was kind of what we focused on including in our survey. But I think, yes, it's very important to also look at SES. I hope we can do that in the future. And but unfortunately, we didn't look at that for this study.
Were all of the organizations, I'm just trying to make sure I remember correctly, were national implementers? Were there any that were?
No. So they were. We had we put out the survey to anyone that's registered as a CDC, well, even non-registered, because we asked them if they are in the DPRP or not. Only a few of them were not or no longer active, but so these are mostly organizations that work within a specific geographic zone. But we do have some online providers who, of course, have more of a national reach.
Okay, thank you.
So Lillian, I had a question around, you know, really looking at this at the organizational level. Usually we do process evaluation, but implementation research is more at the organizational level. And you were able to get a variety of folks to respond both qualitatively through interviews and also through the survey. And so what are your thoughts for why people were so receptive, I guess, to talking about how their organization is doing and functioning and reach? Because, you know, often we think that it may be hard for participants to respond. What are your thoughts about organizational staff kind of responding to these types of questions? You know, whether they're theory-based or not, it's all about how they function and factors related to that.
Definitely. I think, well, the benefit is, and this is one thing we've also found in our coach study, is that the folks that work on this program are extremely passionate about it and are very engaged and want to support any learnings that can come out of this research. And so I think they're slightly more activated maybe than a research participant or in other spaces. There's just a lot of energy around the people that deliver this program. And then of course, definitely have some limitations with bias, because I think the folks that do the lifestyle coach training within DTAC are very much loved by their trainees. So we have a lot, and DTAC does a ton of TA and support. And so that is another limitation, is that since we use the DTAC population, while it is very large and very diverse, these implementers may look different from the national population just because of the different types of TA and training, and they may be, engaged differently. So that worked as a benefit. I had, when you're doing research, you want a good gatekeeper to the population. And so that was DTAC for me, and I'm happy to work with them now. But I think those are probably the reasons. And then, of course, working to make sure that the burden was as low as possible so that we could get a good engagement. And I think that helped. I see Alexandria has a question in the chat about defining reach as a proportion. So I guess I'm thinking like the potential reach, like what does an organization, who is eligible within their patient population or community population to be in this program, and then how many of those can they reach? Also a great question. I don't think many organizations do that calculation. Maybe those that have a patient population, so we know like health systems, they use their patient records to identify who's eligible for the program, and then they're very easily able to send out mass communication and see how many folks enroll. So perhaps some of those, but a lot of folks that deliver this program are also community-based organizations like a YMCA or otherwise. So they might not know who is eligible within their population, or might not be able to find that denominator to really understand what their reach proportion might be. So, but I do like that question, and I wish we could examine that. And maybe that's like a smaller study where we have a handful of organizations that we really can kind of focus on that. I hope that answers my question. Yes, thanks. Great.
Okay, other questions for Lillian?
I have one more then.
Yeah.
In thinking about those smaller organizations that are delivering it and delivering the program to perhaps more narrow populations. I guess what would your suggestions be in order for them to improve their reach, to improve their success, based on your findings in terms of how well organizations across the board are finding success?
Yeah, well, one thing that comes to mind that we also know a lot from our coach work is that knowing your population, if these smaller organizations, if they're working with particular populations, the ideal is that they're very much, connected. They have staff that represent that community. Hopefully, one of the ways in which you do that is you're having lifestyle coaches from that community. And I think that's a great part of this program, is that you can use those, anybody can deliver the program once you're trained. You don't have to have a particular educational background. And so being relevant, resonating with the folks that you're trying to engage and enroll is critically important. And then I think from, that org level, providing your staff with the resources they need to deliver that program well and to keep your population engaged, right? So it's not just, I train my staff, they should do the program, but one thing I think from these org level studies is really having a leadership that has good buy-in for this program and is really willing to do the work to make it successful, you know? So once again, maybe sounds kind of basic, but it's some of those basic things that I think make people successful doing this work.
Last question, Lillian. You had a few outer setting, meaning factors external to the
Sure.
organizations that you were looking at. And I think in the second study, you didn't have any findings related to reach, but is there anything you learned from that in terms of other research or things you wanted to explore?
Yeah, and
Those
this
external factors?
Good question, and also can link it with Leslie's question about CFR updates. So there's now a CFR 2.0 that recently came out that does tease out a lot more of the outer setting in particular. I especially, you know, having done this in the pandemic, there was nothing really to capture that, but now in CFR 2.0, they have critical incidents construct, which is large scale or unanticipated events that disrupt implementation. So yes, you know, it would have been good to have that. I think also the outer setting is now divided up a little bit more to get at some of those population differences that we've been talking about. And I think that would have been particularly useful to use and maybe would have prompted me to collect other things like SES or be able to make those really prominent in here. So maybe that is why I did not see distinguishing things, just because the constructs in the original CFR were kind of big and they contain multitudes of domains and it's hard to, you know, focus on everything. So they did maybe get a little too high level or too watered down to really be sensitive enough for the analysis we were doing. So this work with CFR 2.0 maybe look a little bit different if we do it again.
Great. Last call for any questions. I did just put in the chat the updated article now from Lori Dam-Schroeder with the more enhanced and updated, and she actually broke out some constructs too in inner and outer settings, so that might be helpful for those of you interested in that particular implementation science theory.
Well, thank you so much for having me, Com and Jeff, and it was great to be here.
Great. Thank you all for attending. Our next core C, which is social ecological and behavioral science core webinar, will be in February, so look out for that. Thank you so much, Lillian, for coming and sharing both of your studies. Very insightful work, and we appreciate your being here today. Everybody have a great week.
Bye, everyone.
Thank you.